Hello, good afternoon. It's nice to see you again. By introducing the next session, I'd like to be a bit personal and thank Amy Perrin Ross for taking the moderator's role the whole morning. Amy and myself didn't know each other before this congress or conference, and it's been a great privilege to work with her. But thank you very much, Amy, for taking the whole morning. Whereas we all know that you started at 1 o'clock in the morning in your own country, or 2 o'clock maybe. So thank you. I'm very grateful to you, and it's been a privilege to work with you. This being said, I have the privilege now not to introduce the moderator, but the speaker. For those of you who weren't there the first day and who haven't seen a curriculum, Amy Perrin Ross has a wealth of professional expertise and knowledge on life with MS. As an MS nurse, we are delighted to have her give the closing address of this conference and share with us, in fact, how she sees the future of MS care and the way to improve it further. Amy, I invite you to take the floor.
Thank you so much, Charles. I would like to thank the EMSP for not only inviting me to moderate this session for the last couple of days, but for inviting Charles to co-moderate with me. He has become a delightful friend that I will look forward to interacting with in the future. About 7 or 8 months ago, the EMSP invited me to moderate the program and become involved in putting the program together. And of course, with my history of working with the EMSP, I said yes. But this will be a big job, especially considering I will be starting about 1 o'clock every morning. But it's not a problem. I'm happy to do it. And then they invited me to provide this closing talk about improving the future of MS care. And so now they're asking me to look into the future. At some point, I think I have to learn to say no. But it was a good exercise for me to think about someone like myself who's had a wealth of experience with MS, starting well before any of the disease-modifying therapies became available, watching the therapies grow, our understanding, our knowledge of MS grow. And where do I think or hope that we will see things improving in the future? So let me see, there we go. So as we know, the global prevalence of MS is significant, and this is a geographical drawing from 2014. I would venture to say, honestly, that the proportions or the percentages of people with MS has not changed considerably from country to country, despite the fact that the numbers of people have grown. I think our global prevalence of MS, as we see, is increasing worldwide, in part because we are getting better at recognizing multiple sclerosis. We have a group of people who tend to be very well informed based on their experiences with the internet and blogs and finding information and getting themselves to the healthcare providers earlier and earlier to potentially identify the diagnosis of MS. So this is what the prevalence looks like. So what about the evolution of multiple sclerosis? Well, this slide, courtesy of Professor Peter Calabrese, starts off on the left-hand side of the slide with preclinical information, radiologic isolated syndrome, age, what age are we seeing this disease at? And as you can see at the bottom, we have a number of blue arrows, and that is meant to represent the contrast enhancing lesions, the MS lesions. This is preclinical, before we ever recognize that a person may have multiple sclerosis. How is this possible? Well, with the increased advent of MRI available to people, people are receiving MRIs for lots of reasons, for headache, for head injury, for all kinds of things. And it's interesting to us to find these multiple lesions on an MRI in a person who has not experienced or identified any kind of clinical evaluation. And we not only look at MS now as a disease of people between the ages of 20 and 40, but we're looking at and identifying and recognizing multiple sclerosis starting in our pediatric population. And there has been an explosion of interest in not only the diagnosis of MS in the pediatric population, but importantly, the treatment as well. We move to the middle section of the graph, where we've got clinically isolated syndrome and relapsing remitting disease. And you can see here the MRI activity with the MRI lesions circled, as well as the electron microscopic view of the images of MS. What you'll also notice here is the light blue line, at least on my slide, is starting to slowly decrease. That means we are slowly losing brain volume, something that even as much as 10 years ago we weren't really thinking about. We also look at the yellow line being the clinical course here, where we have our ups and downs and ups and downs. And you'll notice that at least in the beginning, when we go back down, we go to what we call a baseline of clinical activity. So essentially, our people with MS are likely to return to normal. But as time goes on, they may return, but not to where they were previous to the relapse. So they, in essence, will establish a new baseline for themselves. And the red line that we see increasing then is the lesion load. How many lesions do people have on their MRIs, and what does that translate into? And finally, as we move off to the right-hand side of the slide, we look at secondary progressive MS as well as primary progressive MS, starting generally around the age of 40. Now, when I started in MS many years ago in the late 1980s, it wasn't thought that 40 was a young person. These we're thinking 40 is very much a young person. And why is that? Because with the advent of earlier diagnosis and earlier treatment, people with MS are living otherwise longer, healthier lives. Basically, their expectation, their life expectation, has not been decreased at all. Their life expectation is similar to that of other people in their countries with their other comorbidities and things of that nature. And then if we look at the bottom of the slide, we see this sort of decreasing, increasing slope. On one hand, we start off very often with inflammation, and we look at the responses to current treatment. But I wanted to notice the fact that despite the fact that we start off with inflammation, we also start off with some neurodegeneration, albeit a small amount. And as time goes on and inflammation starts to decrease, we see an increase in that neurodegeneration. And I use this slope or an image, something similar to it, when I am talking to people with MS about why it is important to start on a disease-modifying therapy early and why it's important to stick with it. maybe not the same therapy. There may need to be a switch of therapies at various different points in their lives with MS, but sticking with some sort of currently approved treatment to try to decrease this neurodegeneration. Because clearly, when we're talking about degeneration, what is lost cannot be regained. So we move into the evolution of the MS disease subtypes. Early on in the 1990s, Professor Fred Lublin and a group of colleagues put together the 4 different phenotypes, if you will, of multiple sclerosis. Relapsing, remitting, primary progressive, secondary progressive disease, and clinically isolated syndrome. He and his colleagues have reconvened over time and continue to be very active at looking at this evolution. This is not something that is set in stone. It is something that as we as clinicians get more and more information about, he and his group plans to continue to update this. Currently, what we are looking at, again, starting on the left-hand side of the slide, we're recognizing that clinically isolated syndrome, when a person presents with a first and perhaps single episode of some sort of a clinical problem, we're going to look at it and say, okay, it happened, but it's not active, or it happened and it is still very active. If it is still active, we move on to describing it as actually relapsing remitting multiple sclerosis. And in the relapsing remitting MS population, we define those as people who are not actively having new relapses or those who are actively having new relapses. Then the schemata on the right-hand side of the slide looks at primary progressive MS, progressive disease, secondary progressive MS. Primary progressive disease, we talk about active disease with progression. We can also have active disease that doesn't really have any progression, where we're seeing perhaps more of the inflammatory activity. And we can also see progressive disease that is really not active in terms of inflammation, but we do see progression. We can also see disease to the point where it's really not any longer active in terms of inflammatory or new relapse activity, but we also do not really see any more progression. This is stable disease. In the old days, we often would call this a benign type of disease. Well, believe me, it's anything but benign. So this has reframed our whole way of looking at the disease. And as we talk about getting better at diagnosing the disease and earlier diagnosis of the disease, I think it's important for us to realize that this evolution has occurred. No longer are we talking about one day you're relapsing remitting and the next day you're secondary progressive. We realize that there is no hard, fast line that says you're one and then you're the other. There are many, many shades of gray in between, and this is a process that we continue to try to understand and to impact. So what about diagnosing multiple sclerosis, particularly with future biomarkers? You know, currently, the way that we diagnose MS is first and foremost, it's a clinical diagnosis made by a clinician who knows what they're looking at and what they're looking for. They look for things like disease activity in terms of relapses. We look at disease progression in terms of increasing disability. And we're also looking at treatment response. So our future biomarkers, we want them to be very sensitive and specific to the correlates of disease activity. Now, an ideal biomarker for the future will actually guide clinical decision-making by indicating which patients are at the highest risk for inflammatory disease activity, thus providing us as clinicians a guide for selecting among the broad range of treatment options for our patients. Patients often ask me, well, how do you decide on what treatment is best for me? And I say, really, we look at the mechanism of action. We talk to you about what risks and benefits you are willing to assess. In the future, when we have reliable biomarkers, things, for example, like neurofilament light chains, we are hoping that they can point us in a better direction towards choosing a therapy. Also in clinical trials of investigational agents will benefit greatly in terms of cost savings and the speed of advancing trials. If a reliable biomarker can predict success in shorter timeframes than current radiographic or clinical outcomes. For those of you that are familiar with or that follow research clinical trials currently, most research clinical trials for our MS drugs, both the ones that have been done over time and the ones that are ongoing now, rely on MRI activity, expanded disability status scale scores, as well as relapse activity. We can't look at that in a short time frame. We have to look at that for a minimum of 2 years. Now, if we have a future biomarker, again, something such as neurofilament light chains, which is being extensively studied right now, that could perhaps shorten the time of these trials. If we're able to shorten the time of the trial, perhaps decrease the time of a trial from 2 years down to 1 year, that would allow us to move forward with an effective therapy or move on if it doesn't appear that that therapy is effective. If we could move forward, that would allow us to be able to offer this new effective therapy to the general population much sooner than we currently can. So the next slide is looking at the current disease-modifying therapies. So I'm having a little trouble moving the slides. There we go. Okay. So this slide is showing us the existing and emerging MS therapies in 2021. And it's very complex. And there will be a quiz on this at the end of the session. No, I'm teasing. I couldn't even pass that quiz myself. So we start out looking in 1993 with what has very often been referred to as our platform therapies, our interferons and our glutarimer acetate. We moved into the 2000s where we had mitoxantrone, and in 2006, the reintroduction of natalizumab, our first infusible monoclonal antibody. We then moved in late 2010 to our first oral therapy available for the treatment of multiple sclerosis, fingolimod. And I remember back in the late 80s and in the early 90s when the injectable therapies came out, we all said, well, as soon as a pill becomes available, all the rest of these will go away. How little did we know? Yes, fingolimod is a good therapy option, as is teriflunomide and dimethyl fumarate, the two other orals that were subsequently approved worldwide. However, they have not necessarily replaced our platform therapies or natalizumab. Why? Because we are understanding that MS is a heterogeneous disease. It is different in everyone. Therefore, everyone is responding to these therapies very differently. We also moved on to the development of alemtuzumab and ocrelizumab, our first anti-CD20 monoclonal antibodies. We then moved into diroxyl fumarate, as well as siponimod, and then we were able to access cladribine. Again, looking at various different therapy options. And you could see that towards the right-hand side of the slide, we're looking at ublituximab, which is still, the phase 3 trials have been completed, but it is not approved yet by the FDA nor the EMA that I am aware of. And for the future, we're also looking at the BTK inhibitors. For example, evobrutinib, tolerabrutinib, and the others that are listed here. So you see that not only do we have a very rich past, but we've built on that past, and we are moving forward in terms of the future therapies, looking at refining the way that we approach the disease in itself. And those refinements are being made based on the ability to refine our understanding of the disease. So as we move on to the next slide, what are some of these future therapies and what are their targets? Well, we have targets for central nervous system repair, the ibutylast, the clemistine, the temlimab, as well as lipoic acid. Lipoic acid is something that tends to be very readily available, and it certainly is by far one of the least expensive therapies that is being studied for the future in terms of central nervous system repair. Cell-based strategies are also part of our future. We're looking at very specific anti-inflammatory therapies that are based at the cellular level. We're also looking at immunoablation and autologous hematopoietic stem cell transplantation. Part of our angst, if you will, or concern about stem cell transplantation is that there are many, many misconceptions out there about how stem cells are transplanted and actually what can be done and how things are impacted. So it's incumbent upon us as clinicians to talk to our patients about the specifics of autologous hematopoietic stem cell transplant used in multiple sclerosis. We're also looking forward to remyelination. I remember in the early 90s, people talking to me about, well, this inflammation, it keeps breaking down my myelin. When are you going to be able to repair this myelin? When are you going to be able to give me some new myelin? Well, the future of therapies now is aimed at looking at direct cell replacement, because once we damage or destroy a cell, it is no longer functional. So perhaps we could directly replace some of those cells. We're also looking at the utilization of stem cells to deliver trophic factors as well as some endogenous stem cells. And we're also looking at the pharmacologic modulation of endogenous stem cells. So there are lots of different ways and different mechanisms and different approaches going on in these future therapies, and I would anticipate that there will certainly be more as time goes on. So what are some of the factors impacting treatment decisions? Not only treatment decisions today, but treatment decisions for our future. Well, we're certainly always going to be interested in the presence and the positivity and titers for the JCV antibody. Although it was brought to the forefront with the use of natalizumab, it is a factor in many of our other disease-modifying therapies, and I venture to say will probably be a factor in our future therapies as well. We want to think about comorbidities and not just think about them, but do what we can to manage them now so that as we move forward with our disease-modifying therapies, we have people who are overall healthier to begin with and could have positive responses. We also want to be aware of what is the use of previous immunosuppressants. For those of us who rely on private healthcare coverage, we're concerned about insurance coverage. Looking at the experience of the neurologist and the prescribers, we look at patients' lifestyles and preferences. What are the monitoring requirements for this? No longer am I concerned only if you will be taking the medication I have prescribed for you, but I also have to be concerned about whether you are adhering to the monitoring requirements. Are you having your blood drawn on a regular basis after starting certain therapies? And since our population tends to be a young female population, pregnancy is always an issue. As we think about MS care has really evolved from committed, passionate professionals to organized groups committed to the advancement of the profession and the care of those with multiple sclerosis. Groups like the Carers Group that Claire just talked about, groups like EMSP and the MSIF and the DMSG, all of these groups who are advocating the advancement of the profession. And we also have a body of literature, much more so now than ever, that documents the contributions of both MS nursing as well as allied healthcare professionals. Looking at the role of nursing care in multiple sclerosis, compliments of our esteemed colleague June Halper, founder and director of the Consortium of MS Centers. She and the International Organization of MS Nurses have put together this model looking at the types of MS, talking about the ability to establish care, establishing a relationship with our patient and their carers, continuing that care now over many, many years, and sustaining that care, particularly in the face of advanced MS. What about the evolving role of the nurse? What about the future role of the nurse? Well, our knowledge of the disease has expanded to include basic immunopathology. We as nurses are becoming better able to understand MRI techniques as well as diagnostic criteria and the mechanisms of actions of the disease-modifying therapies. I find I'm increasingly called upon to talk about the mechanism of action of therapies, especially in light of the COVID virus. People want to know what these therapies are doing to their immune system, in addition to what the impact is on the potential for either catching COVID-19 or the impact of the vaccines. So through these changes, we still keep our goal of improving the lives of those affected by multiple sclerosis. Next slide, please. Optimizing patient care, we want to recognize the individual perception of quality of life, and we want to use a shared decision-making model, sharing the perspective between the patient and the clinician healthcare goal. This is more likely to involve self-care management practices, and it certainly enhances adherence when we have patients and carers who actively participate in treatment in a collaborative approach. Collaboration is being part of a relationship. It is truly hearing what the person is saying. Let the patient tell their own story in their words and their perspective, and understand or ensure that they understand your perspective. And a good quote is that the patient is the expert in one's own life and the clinician is the teacher. So a multitude of factors contribute to the optimal management of multiple sclerosis. We talk about therapeutic effectiveness, the impact of relapses, disability, cognitive progression, patient and family education, symptom management. All of these things come together to provide the most comprehensive overall MS outcome. And as the IOMSN, International Organization of MS Nurses, discusses quite clearly, a comprehensive team approach with the patient and their carers at the center of this team is what is essential, not only in today's care, but definitely moving forward with the future of multiple sclerosis care. So I would like to thank you for your attention and turn it back to Charles.
Okay, thank you very much, Professor Ross for your excellent presentation. It was quite exhaustive. But we went a bit over time. So from one moderator to the other, I think we are going to skip the question time. Additionally, I think that you have covered the subject in such way that it's almost a plan for the future for the next 5 to 10 years. I'd like to revisit this if I'm still alive in 10 years time and see in fact where we stand. So with your permission, I would like to move to the to the rest of the program. It's my privilege to introduce, in fact, two posters which were selected by the reviewers, and I leave it to the co-author of Chiara O'Meara to comment the first poster. So Chiara, you have the floor.
Lovely, thank you, and I'm delighted to be here. It's lovely to be selected and to be able to present my poster while I'm here. So I suppose my poster is titled Parents' Experiences of a Multiple Sclerosis Diagnosis in Their Young Adult Sons and Daughters. And I undertook this project as part of my master's dissertation in back a few years ago when I did my master's in nursing education in the university in Galway. And the reason I selected this topic was kind of twofold. One, I came from the perspective of a healthcare professional, and also I come as an individual living with multiple sclerosis for the last 11 years. And when I was diagnosed at 23, I was in that early stage as a young adult, very independent of my decision making, in my treatment making. And while it was a very anxious and difficult time for me being diagnosed, it was also a very difficult time for my parents, and something it was a number of years later before I realised that. Research to date that's been undertaken really focuses on parents' experiences when a child is diagnosed with a chronic illness, because they're the primary caregiver. But I wanted to look and see what research was out there on parents' experiences when an adult child is diagnosed with a chronic illness. And it was surprising to learn that there was no research available. So that's what sparked my interest and my reasoning for undertaking my master's project in this area. So as part of it, I interviewed parents to get their experience, their lived experience and their insight to how it was for them when their young adult was diagnosed with multiple sclerosis. And I looked back and analysed all the interviews, and 4 themes emerged for these parents. And it was isolation, lack of support, were 2. And the isolation came from feelings of guilt and fear that parents had. They felt that they had caused the multiple sclerosis. Was it something that they had done as they cared and brought up their child so many years ago? They felt very isolated because as a young adult, you're making your own decisions about your treatment and what's best for you, and they're not really involved as a parent would be if it was a young child. They also looked at, balance was another theme that emerged. Parents found it very difficult to balance how much they could act as a parent and how much they needed to let the individual be independent and to make their own decisions. And parents struggled with that. They struggled on how they could be a parent, but also respect the autonomy and the independence of the individual. A lack of support was one that came out as well, another theme, and parents really struggled with the lack of support and lack of resources that was available. And they said, every parent said to me they wished that there was the opportunity for the MS nurse or somebody to sit down with them and to answer their questions, because they didn't want to be burdening their young adult son or daughter with all the questions they had, because they were trying to get their head around it. And that was something that was very relevant and very pertinent during my project, that parents really wanted that support. And it was something that I think we as healthcare professionals can incorporate into our care of people with multiple sclerosis and those who get a diagnosis, of, you know, how we can involve the parents, maybe at a separate stage, maybe giving them separate literature that they can read, or arranging an appointment where the parents can come in and ask questions. So it really was very interesting for me carrying it out, like I said, as from a healthcare professional perspective and as an individual living with multiple sclerosis. So it's something that I hope will encourage healthcare professionals in the future to look at incorporating the parents of those young adults diagnosed, because at the end of the day, regardless of the age of somebody's child, whether they're 4, 14 or 40, a mum and dad will always be a parent, and they'll always want to care for that individual. So it's now, I feel that my project has now opened the door maybe for further discussion and further research and further action on how we can incorporate parents into this journey for young adults as well.
It's a fabulous project. Thank you very much indeed for sharing your work, your study with us, and your hopes. And we wish you the best with the pursuing of your work. I'm every good luck to you.
Thank you very much.
We had also a second poster, which is not going to be presented live. However, the author, as you can see, Joanna Henschel, has provided a slide that can be discovered on the platform. So for those of you who are interested in the topic, it deals with innovative models of care and shares the result of the evaluation of the neurological enablement service and neurological case management service. The aim is in fact to evaluate innovative models of care and draw out what can be learned from their experiences of improving services. And the objective of this evaluation was to understand more about the value of the services by exploring their impact on people's health and well-being, care and quality, as well as the model's suitability for translation in other areas. I'm sure Miss or Mrs. Henschel would have done better, but that's approximately what I'm able to make out of the documents I was provided with. So that's we're close to the end of this session. I will ask our friend Andrich to show us his drawings of this session. Look at that. Amy Perrin Ross is no longer on the side, she's in the mid. So very good. So I mean, there's a material to take home and look in details, because Andres has been doing fabulous work all the time. So I suggest that you make pictures of them, but they will be available later on in the report of this conference. So I think it is worthwhile to go into details, because not only is Andres a good drawer, but he also understands what we're talking about, which is quite exciting. So it's a sort of resume. Each of his drawings is part of a summary of the day. Amy, we have a couple of minutes. Would you possibly take a question?
Yes, of course, Charles. I'm happy to.
Yeah. In fact, when you were talking about the loss of volume of the brain, but Professor Marcello Moccia yesterday told us that this begins with people being healthy, like we believe we are, that we start losing mass or volume at the age of about 25 to 30 years. Do we have studies that compare the figures of so-called healthy people with persons with MS?
Yes, in fact, we do. As Professor said yesterday, most of our work in terms of brain volume, Charles, is really done in the research arena. In our practice, a large university practice in Chicago, we do not have the ability to measure volume. Some places do, but not all, and by far not the most. So what we know about brain volume really comes from the research clinical trials. The MRI Reading Center in Montreal, there's another MRI Reading Center in Basel, which really takes a look at brain volume. We've identified what would be normal volume for people of all ages. And Professor Calabresi's slide that I showed with the the active, and then the progressive disease, where that line started to show that brain volume was decreasing, that was compared to otherwise normal, healthy people. So we know that people with MS are losing brain volume at a faster rate than what would be expected with normal aging.
Yeah, it's quite important because it has an impact on the way in which we deal with the cognitive support to persons with MS, doesn't it?
Yes.
Which is not easy. I remember years ago, the cognitive side was less known, and it was not considered a major impairment in the beginning. I think that studies have proven to the contrary now.
Oh, yes, absolutely. And we also used to think that people did not display cognitive problems until very late in the disease. And we know that's not true. We can have cognitive problems starting even before people recognize clinical problems. I think we're going to be seeing more and more of that because our cognitive function is so necessary for all of the complex tasks that we're expected to do every day.
Okay, thank you very much, Amy. Thank you. We're going to close the session now. We have a couple of minutes. Stay with us because we are nearing the conclusions of the next session. Will be devoted to drawing the highlights, in fact, of this 3 days conference. So stay with us, and we'll be back.